In this lecture, we'll talk about female genitosexual disorders, and we will cover four topics: dysmenorrhea, endometriosis, premenstrual syndrome, or PMS, and libido and orgasmic disorders in females. The first topic is dysmenorrhea. So the clinical presentation is menstrual pain that starts right before or just after menstruation starts, and usually it subsides within 2 to 3 days. And the underlying abnormality of this pain is believed to be excessive prostaglandin production. Um, the causes can be primary when there is no cause, like physiological, or secondary due to endometriosis or uterine outflow obstruction, when something's stopping the blood flow from the uterus. Red flags: um, pain continues more than 3 days after the menses starts, or pain is getting worse, or if there's a change in the pattern. Usually, this dysmenorrhea pain is predictable, and the female knows exactly when it starts and when it stops. So, if there's any change in the pattern, this requires referral to the physician. So all the following are risk factors for dysmenorrhea, except, and the answer for this question is A. It is actually not obesity. Obesity is not a risk factor. What is a risk factor is being underweight. So females who are underweight have a higher risk of having dysmenorrhea. Female with menstruation starting at the age of 11. This is true. This is what we call early menarche, and early menarche is when menstruation starts before the age of 12. Smoking and history of sexual assault is also a risk factor for dysmenorrhea. Other risk factors include age less than 30, or irregular heavy menstruation, family history, and nulliparity means that never giving birth, like a female who didn't give birth yet. Non-drug measures for the management of dysmenorrhea include smoking cessation, regular exercise, yoga, application of heat, usually to the lower abdomen, and having a warm bath, and high frequency transcutaneous electrical nerve stimulation. This is also one of the non-drug measures that could be used. If the female is seeking contraception, combined hormonal contraceptives are used if not contraindicated. We can also either oral or the vaginal ring. So if the female wants contraceptive, she has dysmenorrhea and she wants to use a contraceptive, then combined hormonal contraceptives are used unless they are contraindicated, and the preferred methods will be the oral or the vaginal ring, like NovaRing. If the female is seeking contraception and estrogen is contraindicated, or if she has dysmenorrhea due to endometriosis, and if the dysmenorrhea is due to endometriosis, and we know that estrogen increase the endometriosis or causes endometriosis, in this case, we cannot give estrogen. We will use medroxyprogesterone acetate. If the female has dysmenorrhea plus she has heavy menstruation, we can use levonorgestrel IUS. If the female doesn't want a contraceptive, then we can use NSAIDs, and NSAIDs typically will start once the pain starts, and it takes taken regularly for the next 2 to 3 days. If the NSAID is contraindicated, we can use acetaminophen, but of course acetaminophen is less effective, because if you still remember on the previous slide, we said that one of the proposed mechanisms or reasons for dysmenorrhea is excessive production of prostaglandin. So NSAIDs will reduce prostaglandin, but acetaminophen will be less effective in this case. Acetaminophen here will be more for pain, but because the pain is prostaglandin mediated, acetaminophen will be less effective than NSAIDs. Ginger, in doses of 750 to 2 grams per day within 3 to 4 days of the beginning of the cycle, has equal effect to the NSAID. Ginger, this is the second time we find ginger to be effective, and we recommend ginger. Generally, if you look at all the therapeutic materials, you will find that recommending natural medicine, always we say there is lack of evidence, weak evidence, palmetto, St. John's wort, cranberry. We always say that. But ginger seems to have the second indication here when they say it has equal effect to NSAID in dysmenorrhea and in nausea and vomiting in pregnancy. So ginger in dose of 750 to 2 grams per day within 3 to 4 days of the beginning of the cycle has equal effect to the NSAID. The first choice is combined hormonal contraceptive or NSAID. Again, combined hormonal contraceptive if the female is seeking contraception, NSAID if the female doesn't want contraception, and we try them for 3 to 6 months. Yes, we use them for few days every month, but we will try them for 3 to 6 cycles, we should say. If they are ineffective, then we can combine them together for another 3 to 6 months. If ineffective, then we reassess. So the NSAIDs here, when we say for 3 to 6 months, that the NSAIDs are only used for 3 days per cycle. Combined hormonal contraceptive are used daily as usual. There is no problem. So when we say for 3 to 6 months, we mean for 3 to 6 cycles, especially for the NSAIDs. They will not be used daily. If ineffective, we combine the use. So combined hormonal contraceptive used as usual every day for 21 days, then 7 days off, while the NSAIDs are used as we described here. They start with the onset of pain and then used regularly for the next 2 or 3 days. If the combination is ineffective, then we need to reassess the condition, and surgical intervention can be considered for refractory cases. The next topic we have is endometriosis. And endometriosis, as you all know, is a chronic, debilitating condition due to the presence of tissue that resembles the tissue of the endometrium at sites outside of the uterus. So there is tissue that is similar to the endometrium tissue, starts growing outside of the uterus. Patients with endometriosis typically have two problems. The first is pelvic pain, and the second problem is infertility. We will talk about both problems on the next slides. However, we will just briefly touch on the management of infertility. In terms of risk factors of endometriosis, there are several risk factors. So Caucasian ethnicity is a risk factor. Early menarche, and early menarche we defined that before. This is menstruation before the age of 12. Females with short menstrual cycle, and short menstrual cycle means a menstrual cycle of 27 days or less. Uh, Females who are tall and underweight. So if you want to put these two together, you can say that females with low body mass index. Nulliparity, which means that a female who never gave birth before. Family history. If a lady has her mother or her sister had endometriosis, this means this lady has a higher risk of getting endometriosis. Females with heavy menstruation. Um, Females with long menstruation that lasts for more than 7 days. And females who have any condition that can impede the uterine flow, any condition that can obstruct the flow of the endometrium during menstruation. So, for example, this can be the growth of fibroids. If the female has fibroids in the uterus, the presence of the fibroids will interrupt and interfere with the flow, with the menstrual flow. Also, if the female has something like uterine polyps, or if the female has any structural abnormalities of the cervix. So all of these factors will interfere with the flow of the menstrual blood, and this can actually increase the risk of endometriosis. There are two factors that are possible risk factors, but we are not clear whether they really cause endometriosis or not, and these are excessive alcohol intake and caffeine intake. There are some factors that can actually prevent or reduce the risk of endometriosis. Um, some of them are the opposite of the risk factors, as we'll see, and some of them are not. So if you have smoking reduces the risk of endometriosis. Being overweight, we said before that being underweight and tall, which means low body mass index, is a risk factor. So actually being overweight and having a high body mass index is a protective factor. We said before that nulliparity, never having kids, is a risk factor. So parity, which means having kids before, this is a protective factor. Also, the use of contraceptives, the intake of N3-PUFA, or the polyunsaturated fatty acid, which is omega-3, and regular exercise. These are protective factors that reduce the risk of having endometriosis. So here we'll talk about the pain management and the infertility management, but the infertility management will just barely touch it. So in terms of pain management of endometriosis, we use the following drugs in order. First choice is NSAID. We start with the onset of menstruation, and it continues for the duration of the period. Opioids can be used as alternative. We can use contraceptives. Contraceptives are 90 to 100% effective, but of course, if the female wants to use a contraceptive, we can use the combined hormonal contraceptives, or we can use progestin-only pills. And the patch and vaginal rings, they also can be used. Can be used regularly, like daily, without stopping, or cyclic. Cyclic is the 21, then 7 days off. Medroxyprogesterone acetate, IM or oral, can be used. Gonadotropin-releasing hormone agonist. We have bozarline, gozarline, nafarelin, liberolide, and the triptorelin, plus add back hormone replacement therapy. When we give gonadotropin-releasing hormone agonist, this will reduce the amount of estrogen and progestin in the body. So that's why, or shut down, we should say, shut down the estrogen and progestin in the body. That's why we need to add back the estrogen and progestin by giving the patient estrogen, like add back hormone replacement therapy, estrogen plus progestin. We can also give gonadotropin releasing hormone antagonists, like elagolix, which is contraindicated in osteoporosis and liver impairment. To be honest with you, these medications are typically medications that are used in like fertility centers and stuff like that. You will not see these drugs in pharmacy much, like in a community pharmacy. Progestin-only IUS is alternative to gonadotropin-releasing hormone analogs. Surgical options such as hysterectomy, it can be an option if there is no concern about infertility, because once the uterus is removed, the female will not be able to be pregnant. But if the female has like established family and she doesn't think about having any more kids in the future, then hysterectomy can be an option. Danazol can be used. It's a synthetic androgen that can be used to relieve the pain, but it's not used because of its adverse reactions. So these are the options in order: NSAIDs, contraceptives, gonadotropin releasing hormone agonist, progestin only IUS, and then we look at the surgical options. Infertility in management of endometriosis, we use clomiphene citrate. Of course, I know that the brand name for clomiphene was discontinued, but clomiphene citrate as a drug is still available in Canada. It's used to induce ovulation in patients with endometriosis-induced infertility, with or without human chorionic gonadotropin mid-cycle. Letrozole 2.5 milligram per day on days 3 to 7 of the menstrual cycle, with or without human chorionic gonadotropin mid-cycle. By the way, the dose for clomiphene citrate is 1 tablet on days 5 to 9 of the menstrual cycle. For clomiphene citrate, the dose is 1 tablet on days 5 to 9 of the menstrual cycle. The next topic we have is PMS, or premenstrual syndrome. So the clinical presentation is that the patient will develop cognitive symptoms such as lack of concentration and mood changes, physical symptoms such as headache, myalgia, weight gain, breast tenderness, pelvic bloating, and fluid retention, and or behavioral symptoms such as aggression, irritability, agitation, and anger during the luteal phase of the menstrual cycle. These symptoms can be severe enough and associated with severe mood changes and impaired functionality. If it's severe enough and associated with severe mood changes, we know this as premenstrual dysphoric disorder, or PMDD, premenstrual dysphoric disorder. The pathogenesis include fluctuation of the sex hormones level, excess prostaglandin in the body, and or low serotonin level. So this is the pathological pathway. That's the pathogenesis. Risk factors include low vitamin D, twins, stress, and being overweight. Management of PMS for non-drug measures. Non-drug measures are effective in PMS, and they include reducing caffeine and salt intake. This is to reduce the salt intake, to reduce the bloating and the fluid retention. Small carbohydrate-rich meal, exercise, stress management, weight loss, and to have enough sleep. In terms of drug therapy of PMS, um, we use NSAIDs, and it seems like mefenamic acid or mefenamate is very effective in this indication. The brand name for this is Ponistan. Also ibuprofen and naproxen, but any NSAID will do the job. We start with the onset of pain and for a short period of time after that, and it helps mainly with the physical symptoms such as the pain and headache. It doesn't help with other symptoms like the behavioral symptoms, for example. Supplements. One of the important things that you need to know is calcium is the supplement that has the best evidence when it comes to PMS. So the dose is usually 400 milligram to 1200 milligram of elemental calcium daily, and it has the best evidence among all the supplements. The lower dose of 400 to 500 milligram alleviates the mild symptoms, while the higher dose reduces water retention, pain, and craving. Magnesium, it can be used. It helps with the fluid retention. Pyridoxine, and we also have other um, natural therapy that some people try, such as oil of evening primrose, uh, chasteberry, and aromatherapy. But the best supplement is calcium. We have pamabrome. Pamabrome is actually a mild diuretic. It's available as OTC, and it's commonly used in combination with acetaminophen. It has mild diuretic effects, so it reduces the bloating, and it can be used in combination with pyrilamine, which is an antihistamine. If the female develops the premenstrual dysphoric disorder, then we can use SSRIs. SSRIs for this indication can either be used daily or cyclic only during the luteal phase for few days. So that's the second time we use SSRIs as needed. A few minutes ago, we used fluoxetine and sertraline and paroxetine as needed for premature ejaculation, 3 to 6 hours before intercourse. Now we use SSRI for a brief period of time during the luteal phase of the menstrual cycle to control the PMDD, or premenstrual dysphoric disorder, symptoms in females with premenstrual syndrome. Now we'll move to libido and orgasmic disorders in females. So there are some definitions here that we have to know. I don't think you have to memorize. Females have two major problems: have sexual arousal disorder and have orgasmic disorder. So the sexual arousal disorder is defined as having three or more indicators being absent or reduced for 6 months. So we have a list of indicators here. If these indicators, if 3 or more of these indicators are absent or less than usual for 6 months, then we say that the female has sexual arousal disorder. Okay, so what are these indicators? Interest in sexual activity. So if there is no interest in sexual activity, or it's less interest in sexual activity for 6 months, this will be one of the indicators being absent or reduced. Sexual thoughts, initiation of sexual activity, and being unresponsive to partner's stimulation, pleasure during 75% of the sexual encounters, or genital sensation during 75% of sexual encounter. So these are the indicators. If these indicators are absent or less than usual for 6 months, we say that the female has sexual arousal disorder. The second class of libido and orgasmic disorders in females is orgasmic disorder. Orgasmic disorder is defined as having significant delay or absence of orgasm and or markedly reduced intensity of orgasm, okay, that affects 75% of sexual encounters, and this continues for 6 months. That's when we say that the female has orgasmic disorders or disorder. Now, do I have to memorize these definitions? I don't think you will need to. You need to know the symptoms, you need to know the indicators, so you understand what's going on, but I don't think you have to memorize, like, the details of the definition. First, we'll start with the non-drug measures for the libido and orgasmic disorder. So the first one is to manage the underlying mood disorders. If the female has an anxiety or depression, we need to make sure we manage this. Um, I'm not sure why they put this as non-drug measures, but I believe, even though we use drugs, but I believe because it's the drugs used here are not for the libido and orgasmic disorder. So, if the female has an anxiety or depression, we can try to use medications that are sex-neutral agents, such as bupropion, vortioxetine, or vilazodone. You may look here and say, where is the mirtazapine? Mirtazapine also can be used. And it's believed that the improvement of the sexual activity by controlling depression exceeds the sexual adverse effects of antidepressants. So even if you will not give bupropion and you will give something like citalopram, there is no problem. The effect of the citalopram on improving sexuality is more than the sexual adverse reactions of the antidepressants. Uh, Also, counseling is important, especially if there is inadequate intimacy. If the relation itself is not going well and there is no intimacy in the relation, then counseling is important. Also, to discuss the importance of non-physical, non-genital, and genital non-penetrative stimulation. Non-physical will be something like romantic talks. Non-genital will be something like kissing. Genital non-penetrative stimulation would be something like oral sex. So this is also very important to be discussed with the partners. Avoid distracting psychological factors such as pain, stress, anything that causes distraction during the intercourse. So pain, stress, self-monitoring is everyone is focusing on himself more during the relation and on his own enjoyment. Being overwhelmed by body image. Don't think too much about your body image or gaining weight or feeling that you don't look good physically. So this is something also the patient has to avoid. Also, other factors that can cause distraction is partner sexual dysfunction, when the person is worried that the other partner is not enjoying. Also, the couples must avoid distracting biological factors such as fatigue. So don't have intimate relation when the person is tired. Medications, if there's any medication that can affect the relation. Vaginal dryness, so they can use like a lubricant. If there is a problem with incontinence or hypothyroidism, like when we say avoid here means also to optimize the management of these conditions if there is a treatment to be used. Females with orgasm disorder, they may try vibrostimulation. These are the vibrators that females can use to stimulate themselves sexually. Coital alignment to ensure that more pubic to pubis contact. So this is during the intercourse to find the relation that to find the position that allows more contact between the pubis area in the female and the pubis area in the male, because this has a sexual stimulatory effect. And also guided self-stimulation. That's when the female will tell the male partner what she likes during the relation, so the male partner can focus more on actions and things that makes the female partner more aroused during the relation. So in terms of drug measures for libido and orgasmic disorders, we can use vaginal estrogen. Vaginal estrogen is used when the disorders are attributed to menopause symptoms such as vaginal dryness. Also, vaginal lubricants can be used for dryness and for pain due to dryness. We can also use vaginal androstenolone, which is also known as dihydroepiandrosterone. This is actually an endogenous steroid, sterol in the body, and it's available as a supplement that could be used. It's used to increase desire. It also used to increase coital comfort and facilitate reaching the orgasm. And the effect is not due to increased estrogen level, like it does not increase the estrogen level. We can also use transdermal testosterone. It can be used off label for females with this desire disorder, but the studies didn't show benefit, and the safety is not established. In fact, I came across one female patient who was using testosterone for sexual desire. And also, we can use sildenafil. Sildenafil improves the ability and improves the time to reach orgasm in females with antidepressant-induced sexual dysfunction, but it doesn't improve arousal. It doesn't have aphrodisiac effect. This is what we already mentioned with the males. So sildenafil in females has two major effects: improve the ability, so it's easier for the female to reach the orgasm, and the time, so the female will reach the orgasm faster. And this is mainly in the setting of antidepressant-induced sexual dysfunction. We have one drug that we'll talk about, which is flibanserin. This drug is important, guys. You need to know this drug really well. So, flibanserin is a drug that increases the dopamine activity and transiently reduce the serotonin activity by acting as agonist-antagonist on certain serotonin receptors. This drug, the effect, it improves sexual satisfaction and desire, but does not improve sexual performance. So it improves sexual satisfaction and improve sexual desire without improving the performance. Um, the indication, it's used in premenopause females with low sexual desire because it improves the desire and the satisfaction. Contraindications, it's contraindicated in patients with hypersensitivity, in females with resting systolic blood pressure less than 110 or diastolic blood pressure less than 60, in patients who use resting systolic blood pressure less than 110 or diastolic blood pressure less than 60 in patients who use alcohol. Okay, so if the patient is using alcohol, we need to check the resting systolic and diastolic blood pressure. We need to make sure that if the systolic is less than 110 or diastolic is less than 60 in females using alcohol, then we cannot use this medication. Also, pregnancy. Animal studies suggest some fetal toxicity, breastfeeding, hepatic impairment, and concomitant use with strong or moderate cytochrome P3 or 3A4 inhibitors such as azoles, macrolide protease inhibitors, ciprofloxacin, diltiazem, verapamil, and grapefruit juice. So adverse drug reactions. Adverse drug reactions will also speak to the contraindications. So they cause severe hypotension and syncope. Severe hypotension and syncope. And that's why before we give them, we need to check the systolic blood pressure, make sure that it is not less than 110, and the systolic blood pressure to make sure it is not less than 60 in females who are using or taking alcohol. So, because we know that alcohol can further reduce the blood pressure. So, severe hypotension and syncope, the risk increases with alcohol. That's why we have to be careful in this group. Cytochrome P3A4 inhibitors and cytochrome P2C19 poor metabolizers. Potential memory carcinogenic effect. Palpitation, the risk increases with alcohol, so we use with caution in patients with heart conditions, and it can cause sedation. The patient should avoid driving for at least 6 hours after the dose, and alcohol also increases the risk of sedation. These are the serious side effects. Common side effects include dizziness, drowsiness, nausea, fatigue, hyperthermia, headache, upper respiratory tract infections, and insomnia. And we have also some less common side effects such as vertigo, balance disorders, increase the prolactin level, visual impairment, gastric ulcers, gingivitis, anorexia, depressed mood, agitation, hallucination, dry mouth, urticaria, and paresthesia. I believe the serious are more important to know. And apparently, you can tell that alcohol is also very important to keep in mind that this drug, if it's taken with alcohol, this can increase the risk of multiple serious adverse reactions. Again, flibanserin is a drug that needs you to give it a good read. Like, this is an important one. We have lots of drug interactions of flibanserin here. So flibanserin is a substrate of cytochrome P3A4. So for the strong inhibitors, strong or moderate inhibitors, these are contraindicated, and we allow 2 weeks of washout period after the 3A4 inhibitors and before starting flibanserin, and 2 days washout period after the flibanserin before starting the 3A4 inhibitors. And the 3A4 inhibitors that are contraindicated were listed on the previous slide: the azoles, antifungals, the protease inhibitors, ciprofloxacin, verapamil, diltiazem. Cytochrome B3A4 weak inhibitors. Okay, the weak inhibitors will increase the level, but not too much, so we can use them. We can use them with the flibanserin. The moderate inhibitors and the strong inhibitors are contraindicated, but weak inhibitors such as oral contraceptive cimetidine, fluoxetine, Genco, ranitidine, uh, resveratrol, these increase the flibanserin level. Cytochrome P2C19 inhibitors, such as proton pump inhibitors, selective serotonin reuptake inhibitors, benzodiazepines, and antifungals, they increase the flibanserin level, so we have to be careful. 3A4 inducers, such as rifampin, phenytoin, carbamazepine, they reduce the flibanserin level. If we can avoid the combination, this will be good. CNS depressants, such as benzodiazepine and opioids, increase drowsiness. Aspirin and NSAID increase the risk of GI bleeding. And flibanserin is P-glycoprotein inhibitor, increase the level of digoxin and sirolimus. Dose is important for flibanserin. So it's 100 milligram orally at bedtime to reduce the risk of hypotension, syncope, and drowsiness. Skip the missed doses. If there is no improvement in 8 weeks, we discontinue therapy and we need to store it at room temperature. Again, flibanserin, guys, is an important drug to keep in mind.